If a surgeon cuts into, like, a patient's abdomen, we fully expect the body to just completely reroute its internal plumbing to adapt.
Right, it's a massive undertaking for the body.
Exactly. So why, for literally decades, did we assume the most densely innervated, vascularized microenvironment in the female body would just, I don't know, bounce back from a scalpel?
It's a huge oversight, honestly.
Yeah. Today, we are looking at aesthetic surgery through a completely different lens. Welcome to the Deep Dive. I'm so glad you could join us because we're tackling a topic that requires us to completely rethink how we view the human body's capacity to heal, adapt, and, well, occasionally fail.
Absolutely.
Our mission for this deep dive is to explore exactly how previous labiaplasty surgery alters the lymphatic drainage and the dermal tissue planes of the remaining vulval tissue.
What's fascinating here is that labiaplasty is so often viewed by the general public, and sometimes even within broader medical circles, as just a purely cosmetic or, surface-level adjustment.
Right, like a quick trim.
Exactly. But when you actually examine the underlying biology, this procedure fundamentally re-engineers a highly complex microenvironment of blood vessels, nerves, and microscopic transit pathways.
And to understand that biological reengineering, we've pulled together a really diverse stack of sources for you.
Yeah, we're covering a lot of ground today.
We really are. We're synthesizing anatomical cadaver studies, clinical reviews on aesthetic surgery complications, cutting-edge indocyanine green or ICG lymphography mapping, and even genetic data straight from the NCBI regarding the TGFB1 gene.
We're basically traversing from the macroscopic surgical choices all the way down to the microscopic cellular response.
But I guess before we can understand how surgery alters the tissue, we probably need to understand what's there to begin with, right?
Yeah, we definitely must establish the baseline native architecture first. The cadaver studies in our sources provide this remarkably detailed blueprint of the labia minora, starting with its vascular network.
It was pretty intense.
Very intense. The blood supply here is not singular at all. It relies on a highly specific segmental delivery system.
So it's got backups upon backups.
Precisely. It features a dominant central artery, an anterior artery, and two posterior arteries. And all of these are fed by branches of the internal pudendal and perineal artery.
That level of redundancy is incredible, but it's intertwined with an equally complex, and I'd say far more fragile, lymphatic system.
Oh, without a doubt.
Because the lymphatic drainage of the anterior labia relies heavily on the presymphysial plexus. And instead of just a simple drainage tube, it acts as this dense microscopic catchment area right at the pubic bone.
Right, it's filtering interstitial fluid before it ever even reaches the deeper superficial inguinal or deep femoral nodes.
And the complexity of that catchment area is just compounded by extreme anatomical variability, isn't it?
Yeah, that's the kicker. Anatomical studies consistently demonstrate that there is no single solitary lymph node designated to drain the unilateral vulva.
Which seems wild given how much we map the human body.
You'd think we'd have it standardized by now. For decades, medical texts heavily referenced the Cloquet or Rosenmuller node, positioning it as this critical junction point between the deep femoral and external iliac systems.
But the modern research kind of blew that up, right?
It completely did. Modern anatomical research reveals that only about 8% of individuals actually possess nodal tissue at that exact textbook location.
8%. Okay, so if we think of this like a subterranean transit grid, like a city's water and subway lines, every single city possesses a completely unique layout for its stations.
That's a great way to picture it.
But then, if every single patient's drainage is that highly variable and it doesn't map perfectly to one specific node, how does a surgeon even begin to navigate this without causing a massive transit failure?
Well, modern anatomical mapping is finally providing the answer and simultaneously rewriting our understanding of the tissue entirely.
Tell me of the ICG study.
Yeah, so the sources highlight this pivotal study utilizing ICG lymphography. It's a fluorescent dye imaging technique used to track lymphatic flow in patients presenting with native labial hypertrophy.
Because historically, didn't some clinicians guess that hypertrophy was just like a localized form of lymphedema?
Exactly. They just assumed a fluid backup was driving the tissue enlargement.
So when they actually ran the fluorescent ICG dye through these patients with hypertrophy, what did the fluid dynamics reveal?
The imaging demonstrated completely clear, highly functional superficial lymph flow. Native hypertrophy is definitively not caused by lymphedema.
Wow, to know.
But what the mapping vividly illustrated was the sheer density of this native lymphatic network. For decades, surgeons were treating post-operative swelling as a localized tissue problem.
Right, just a bit of local inflammation.
But the ICG mapping proved it's actually a systemic transit problem. When an incision is made, the surgeon isn't just removing excess tissue, they are unknowingly severing dozens of primary transit highways straight out of the area.
Okay, let's unpack this. If the native transit network is this dense and highly variable, the actual surgical techniques must be altering these dermal tissue planes in drastically different ways.
Oh, completely.
Looking at our clinical reviews, surgeons primarily rely on three distinct structural approaches. Let's examine the mechanical reality of the most traditional approach, the trim technique.
Right. So the Trin technique relies on a linear excision of the free border, which is the outer edge of the labia minora. You are basically creating a direct vertical breach through the tissue.
But based on our anatomical blueprint, cutting along that outer edge effectively amputates the terminus of the neurovascular highway.
That's exactly what happened.
You are deliberately removing the most densely innervated and highly pigmented portion of the anatomy.
Yeah, you are incising perpendicularly across thousands of delicate microvessels and nerve endings, and recognizing the functional loss associated with that amputation, a lot of surgeons pivoted to the wedge technique.
Okay, how does the wedge work?
This approach removes a V-shaped section from the central portion of the tissue. By excising the center and bringing the two remaining sides of the V together, the surgeon preserves the natural neurovascularly rich outer edge.
Which sounds better at first. But the biomechanics of a V-shaped excision introduce a severe structural vulnerability, don't they?
Yeah, they do.
Because when you force the edges of a V together, the physical vector forces converge at the very bottom of the incision. The apex becomes a point of extreme mechanical tension.
Exactly. Structural engineers refer to this as stress concentration. And our sources note this localized tension dramatically increases the risk of wound dehiscence.
Dehiscence, which is just the clinical term for the tissue margins physically separating and pulling apart, right?
That's right. The clinical reviews provide a highly revealing case study on this exact complication. The data highlights 3 specific patients who suffered catastrophic suture dehiscence following a wedge procedure.
And there was a connection between them.
Yes, the single unifying variable among them was that they were all active smokers.
Which perfectly illustrates the biological mechanism of failure here. Because nicotine acts as a potent vasoconstrictor. It physically shrinks the microcapillaries, restricting blood flow and starving the localized tissue of oxygen.
It's a recipe for disaster.
Right. When you combine oxygen-starved tissue with the extreme mechanical stress concentrated at the apex of a surgical wedge, cellular necrosis is almost inevitable. The margins literally just die and pull apart.
Yeah, the microvascular network simply cannot supply the biological resources required to bridge that high-tension gap.
Makes sense.
So if the trim technique amputates vital nerve endings and the wedge technique introduces catastrophic mechanical tension, surgeons sought a structural loophole.
They needed a third option.
Right. They needed a method to reduce physical bulk without amputating the delicate edges or engineering a high-tension apex. And that logic drove the development of de-epithelialization.
Okay, de-epithelialization targets only the central surface epithelium layer, so the superficial skin. The surgeon removes that top layer and then physically folds the underlying core tissue inward, suturing it down to reduce the bulk from the inside out.
That's the theory behind it, yeah.
But I have to push back on the mechanics of this. If you are physically folding the core tissue in on itself and suturing it into a compact roll, how does that not completely kink or block the lymphatic vessels trapped inside that folded dermal plane?
That is the critical vulnerability of the technique, and honestly, it highlights a fundamental surgical reality. Any physical manipulation, whether it's an amputation, a high-tension wedge, or an internal fold, severely disrupts the dermal tissue planes.
It's unavoidable.
Completely. De-epithelialization forces the body to rely entirely on its systemic healing cascade to reestablish flow across those newly folded planes. In fact, the procedure dictates that the native labia must be a minimum of 3 millimeters thick to even attempt this.
Wait, why 3 millimeters?
Because if the tissue is thinner, the physical fold will completely choke off the subdermal blood supply, inducing immediate ischemia.
Here's where it gets really interesting. We've established the mechanical cuts and folds, but what is the immediate biological reality for fluid drainage the moment those dermal planes are disrupted?
Well, an aggressive inflammatory cascade initiates instantly. The moment the dermal planes are breached, local capillaries dilate.
They just open up.
Yeah, the cellular walls become highly permeable, essentially opening the intercellular gaps to allow plasma proteins and white blood cells to flood out of the bloodstream and into the surrounding interstitial space.
And this vascular permeability is what drives the acute swelling, which our clinical sources note typically peaks between, 48 and 72 hours post-operation.
Exactly. But remember, the lymphatic vacuum cleaners meant to clear that interstitial fluid have just been severed or folded over.
Oh, right. So the fluid is just dumping in with no way out.
The fluid continuously leaks into the tissue, but the primary return pathways are compromised. We observe similar fluid dynamics in other aesthetic procedures, but the systemic response varies wildly based on the anatomical region.
Like with a tummy tuck.
Right. Consider abdominoplasty. When surgeons elevate the dermal tissue across the entire abdomen, they sever vast networks of lymphatic pathways.
So what does the body do?
Post-operative studies demonstrate that the body's lymphatic flow often completely redirects to adapt. Interstitial fluid that historically drained downward into the inguinal nodes in the groin actually reverses course, shifting to drain upward into the axillary nodes in the armpits.
That is crazy. The body just forces an entirely new macro route. But vulvar surgery operates in a much tighter, vastly more volatile microenvironment, right?
It does, and if the deep lymphatic vessels in the pelvic region are severely disrupted, the fallout is catastrophic. Gynecologic oncology provides a really sobering benchmark in our sources for this.
What happens in those cases?
Well, during certain cervical cancer surgeries, deep pelvic lymph nodes are intentionally excised. The resulting lymphatic fluid backup can be so aggressive that patients develop giant vulvar lymphangiomas.
Which are what, exactly?
They are massive, permanent, fluid-filled dilations of the remaining superficial tissue.
Oof. Okay, applying that benchmark to our aesthetic labiaplasty patient, they aren't losing deep pelvic nodes, obviously, but their superficial transit lines are suddenly and violently severed.
It's a sudden loss of the primary transit pathways, yeah.
So it's basically like a major highway closure. The superficial lymph fluid is forced to rely entirely on collateral vessels, the microvascular neighborhood side streets, to clear this massive influx of fluid.
That's a perfect analogy. And if we connect this to the bigger picture, the body's ability to resolve that acute postoperative swelling relies entirely on lymphangiogenesis.
Building new lymph vessels.
Right. Those microscopic collateral vessels must biologically develop, mature, and rapidly take over the localized workload to bypass the surgical trauma zone.
But if those collateral vessels fail to mature efficiently, or if the surgical scarring creates a barrier that is simply too dense, the fluid has nowhere to go. The transit system remains gridlocked.
Exactly. And this specific mechanism is driving a massive paradigm shift in aesthetic surgery right now. When patients experience persistent low-level swelling 6 months or a year after surgery, it isn't necessarily just slow healing.
It's something more permanent.
It frequently represents low-grade lymphatic dysfunction, a permanent reduction in the efficiency of the local transit system. Acknowledging this reality requires modern surgeons to focus just as heavily on preserving invisible lymphatic integrity as they do on visible vascular anatomy.
It's a fundamental shift from asking, did the tissue survive the excision, to asking, can this tissue effectively process fluid a year from now?
Exactly.
And to truly answer how the remaining tissue biologically alters itself long-term to survive that, we have to zoom all the way down to the genetic and cellular level. We need to look at how the body physically rebuilds those severed dermal planes.
And the genetic data from the NCBI regarding the TGFB1 gene provides the mechanistic answer to that rebuilding process.
TGFB1, so that's located on chromosome 19q13.2, right?
Yes, TGFB1 transforming growth factor beta 1.
Let me translate this for you, the listener. Why should you care about this specific gene on chromosome 19? Why does it dictate the success or failure of a surgical outcome?
Because TGFB1 operates as a master biological regulator. It dictates cellular proliferation and differentiation throughout the entire body.
Okay.
In the specific context of our surgical remodeling, it heavily dictates the positive regulation of the collagen biosynthetic process and extracellular matrix assembly.
So it's essentially the biological contractor directing the microscopic rebuilding of the structural scaffolding in the remaining vulval tissue.
Yes, exactly. And this cellular contractor utilizes highly specific pathways. Our sources highlight EMT, which is epithelial to mesenchymal transition, and angiogenesis.
What does EMT do in this context?
EMT allows static epithelial cells to change their functional state, becoming mobile repair units. Combined with angiogenesis, which is the formation of new blood vessels, these processes are the biological tools required to reconnect disrupted tissue planes.
And build the new collateral lymphatic channels we were just talking about.
Precisely. But the critical variable dictating how TGFB1 utilizes those tools is mechanotransduction.
Mechanotransduction. Okay, break that down for us.
This is the biological process where a physical force, like the localized tension from a surgical suture, is translated into a chemical response at the cellular level. When tissue is placed under high mechanical stress, the TGF-beta signaling pathway becomes hyperactive.
Oh, I see. So instead of carefully laying down a delicate, functional extracellular matrix, an overactive TGF-B1 response triggers hyperactive cross-linking.
Exactly, the body
It
panics.
weaves the collagen lattice far too tightly, creating this rigid, impenetrable barrier. It results in fibrosis.
Yes. Which brings the microscopic cellular biology perfectly in line with our macroscopic surgical choices. Recall the wedge technique and that critical concept of tension-free closure.
Right.
Less mechanical tension applied to the wound margin translates biologically into a balanced, controlled TGFB1 signaling pathway. When the tissue is not under severe physical stress, the cellular contractor can lay down smooth dermal planes and facilitate the development of functional open lymphatic vessels.
But introduce high mechanical tension at the apex of a wedge, or, combine it with poor blood flow from nicotine-induced vasoconstriction, and you trigger severe mechanotransduction.
It's a chain reaction.
The TGFB1 pathway oversignals, and the resulting hyperactive cross-linking permanently chokes off the surviving microcapillaries and lymphatic vessels. The macrosurgical choice directly dictates the microgenetic response.
It is a beautifully complex, highly reactive ecosystem. The body is constantly reading the mechanical environment of the tissue planes and translating that physical reality into chemical signals to completely alter its own architecture.
So what does this all mean? We started this deep dive looking at a procedure often dismissed as a simple, surface-level trim. But synthesizing these diverse sources reveals labiaplasty to be a profound systemic alteration of delicate dermal tissue planes and a highly variable native lymphatic network.
It's so much more than skin deep.
It really is. We've learned that the remaining tissue's survival depends entirely on collateral vessels acting as transit detours, and on master regulatory genes like TGFB1 interpreting mechanical tension to properly rebuild the extracellular matrix.
And the resilience of this microenvironment is absolutely incredible when managed with precision. And, looking at the trajectory of the research, there's a fascinating proposition on the horizon.
Ooh, what's that?
Well, we know ICG lymphography is heavily utilized in postoperative research settings to map the vulva and study conditions like lymphedema, right?
Right.
What if, in the near future, surgeons routinely used live ICG lymphatic mapping during the labiaplasty procedure itself?
Wait, really moving the imaging technology directly into the operating room?
Exactly. Rather than relying on generalized anatomical blueprints, where we know key structural nodes are only present in 8% of individuals anyway, a surgeon could dynamically visualize the patient's unique, highly variable transit lines in real time.
Oh, wow. They could theoretically custom design their incisions to weave perfectly around the native lymphatic pathways.
Yes. Bypassing the native lymphatic highways completely could drastically reduce acute post-op swelling and effectively eliminate the long-term risk of low-grade lymphatic dysfunction.
That entirely changes the surgical landscape. It transforms aesthetic surgery from an educated anatomical guess into a purely functional precision science.
It perfectly bridges the critical gap between preserving the microscopic biology and achieving the macroscopic aesthetic goal.
The human body's ability to adapt and rewire its own transit grid is nothing short of miraculous, but it certainly helps when we finally have an accurate map to guide the remodel. Thank you so much for joining us on this deep dive. We hope this exploration gives you a completely new appreciation for the incredible, unseen biological architecture operating just beneath the surface. Keep questioning, keep learning, and keep exploring.